got a flick of the air that you can. So thank you so much, Fiona. I'm sorry about my hopping. I was hiking in the Pyrenees and broke my ankle. Recovering, just about to get over it. So it's a real honour for me to be here, and thank you so much for the invitation, and thank you, Fiona, for a lovely introduction. And also to Matthew for a beautiful welcome to country. I think in this room, which is so beautiful, we're really reminded of the connection to country. I'd like to acknowledge the Bedegal people, myself, acknowledge their care of the country. And I think what Matthew told us to do, that we have a responsibility to care for that. And I guess that's really what my talk is about. I'm honoured to present this particular oration, the Ian Webster oration. It's a topic that's close to my heart, and it's been a focus of my career for 30 years. In preparing for this oration, I actually went back and looked at Ian's research over the decades and came across some of his reflections on his own career published in Drug and Alcohol Research Connections in 2014. As many in the audience well know, his passion for tackling disadvantage, for creating health for all, and for making a difference is deep and long held. As a university student, in his reflections, he said that he and his friends were seized by the idea that they had to identify with those most marginal and disadvantaged. And so a career in health for all was born. So this article actually prompted my memory of when I first came across Ian's work, and it was nearly 40 years ago during my first attempt at an academic career. Ian reflected that one of his proudest achievements was his role in establishing the highly influential National Drug and Alcohol Research Centre in 1986. At the same time, on the other side of the country, I was just starting out my academic career. I was a foundation member of a team at its sister centre in Perth, the National Centre for Research into the Prevention of Drug Abuse. It's now the National Institute for Drug Research. Good idea to change the title. Working initially with the interim director, Professor Colin Binns, who's in the photograph here, and then its foundation director, Professor David Hawkes. I'd been undertaking a master's degree in health promotion at Curtin University while working full-time as a market research consultant. And with my supervisor, who was Colin Binns, quite remarkably, I won a $34,000 grant from the Department of Community Services and Health in 1986 for a study on women's use of alcohol and illicit drugs. It became my master's thesis. The grant success prompted me to want to study full-time. So I left my commercial market research position, where I'd been somewhat unhappily studying how to market yogurt to customers, along with monitoring the beer market nationally. Now, I hadn't learned a lot from my market research on yogurt, although no offence to any yogurt researchers in the audience, there must be more to life than doing market research on yogurt. But I did learn an important lesson from monitoring the beer market nationally that stood me in good stead in my public health career. Commercial companies are ecstatic when they win a 1% market share in a new market, and they accept that market growth is often slow. But in public health, the task is much harder. If we want health for all, we need to shift whole populations. We need to target those who least want to buy our product. In health promotion, it's about to drink less alcohol, to eat less fat, to exercise more, to eat more fruit and veg. And even as a junior academic, it was pretty clear to me that while health messages and attitude change programs are necessary, alone they are insufficient to change whole populations, particularly those who are most vulnerable. If we want to shift whole populations, it requires a much more comprehensive approach with both sticks and carrot strategies, with efforts to actually reduce inequities in access to opportunities. So after completing my master's degree, I resigned my job at the National Centre. Bill Saunders, who was a friend and then the Professor of Addiction Studies, said to me, "What on earth are you going to do?" I said, "Well, I'm going to become a tiler." He looked at me and we were walking past a tiler. I said, "The tiler there, yesterday he was up to there, and today he's up to here. He can see where he's going. I can't see where I'm going." So in other words, as an early career academic, I had no goal about where I was going and what I was trying to achieve. And this early insight from my first failed attempt as an academic is captured by a quote by essayist and philosopher Thomas Carlyle, whose quotes I noticed you quoted in your article, Ian, as someone who inspired you. A man, or in this case a woman, without a goal is like a ship without a rudder. Now, I did return to academic life in 1992 after accepting a position at the University of Western Australia. I was on a team evaluating the impact of the Healthway, the West Australian Health Promotion Foundation. This time I had a very clear goal. I wanted to return to academic life. I wanted to start a PhD part-time, but this time I was a late starter and I wanted to tackle a topic that I found interesting, but also that might be important. Lesson number 2. So in 1986, the World Health Organization had published its Ottawa Charter setting out the goals for health promotion, which it wanted its member states to implement. 2 of these related to changing the environment. The first was about creating healthy public policy, changing not just health policy, but actually creating all policy to be healthy. And the second was to create supportive environments. I wanted to combine the 2, to study how environments were supportive of physical activity. In my case, I chose one behaviour, and what policies could be changed to create those environments. Next, I needed a theoretical framework to underpin the research that I was undertaking. In 1992, social ecologist Dan Stokels published a paper about establishing and maintaining healthy environments towards a social ecology of health promotion. Dan highlighted in his article that concurrently we need to consider the multiple levels of influence on behaviour, individual and social environmental factors, as well as physical, policy and built environment factors. Now, if you combine the 2, the World Health Organization's environmental and policy goals, together with Dan's social ecological framework, it provided me with the inspiration and imagination that I needed to tackle a PhD that satisfied my criteria. It sounded pretty interesting, and it sounded like it possibly was important. Little did I realise that this research would be at the forefront of an exciting new field of research to which I contributed from the outset. The field is now massive. It's got people from urban planning and health programs being taught across the country in schools of population health, architecture design and the built environment. I did a quick Web of Science search to see what sort of publications there are now. And in 2023, there were over 300,000 papers, if you use the keywords environment and health. And in 2020, I can't really believe I'm so excited about this, for the first time in this now quite well-established field, it was given its own Australian Research Council, FOR code, Urban Planning and Health. I don't know why that makes me feel so happy, but suddenly it felt like we'd made it. Yet over the decades, the nature, the complexity and the sophistication of this health-related evidence-based field has changed very dramatically. Initially, its focus was narrow. It was about examining associations between health behaviour, such as physical activity, which I tackled, and built environment features, such as access to walkable environments and green space, and how this might vary by socioeconomic status. But over the years, the field's really evolved. It draws in researchers not only from health, but from multiple disciplines: transport, urban planning, architecture, housing, urban greening, urban analytics, ecology, and computer science, to name just a few. Many outstanding researchers are here at University of New South Wales. They're built environment and health pioneers. Susan Handy, who's in the architecture school. Urban greening researcher, Professor Xiaoqi Feng. Policy researcher, urban policy researcher, Dr. Patrick Harris, and geospatial scientist, Professor Chris Pettit, to name a few. And we're going to be hearing several presentations later this afternoon or this morning. Now, the creation of these multidisciplinary teams for all these different fields has strengthened our understanding of the problem, how to measure it, as well as the solutions and the way forward. Working with policymakers and practitioners has become more of a standard way of working, a standard practice. And it gives me a thrill when I hear policymakers and practitioners outside of health raising concerns about the health impact of the built environment, of their built environment interventions. And this is happening more and more. In my own case, I've really moved from developing conceptual models about single behaviours to thinking more in more complex conceptual models, systems approach that consider the city planning factors that influence not only human health, but ecosystem health and planetary health. Now, we all know that cities are the powerhouse of the economy. They provide access to employment, to education, to social and cultural opportunities, and many resources. But when they're poorly planned, as I feel we are doing at the moment with car-centric planning, it fosters both unhealthy and unsustainable lifestyles. It's exposing us to a whole range of environmental stressors, to traffic, air, noise pollution, nocturnal light pollution, to heat island effects and to congestion. It contributes to biodiversity loss, and it's exacerbating inequities in both access to infrastructure and resources, and it's fostering, as a consequence, locational disadvantage. By 2050, around 70% of the world's population is going to be living in cities. And even though Australia is a highly urbanised nation already, two of our cities, Sydney and Melbourne, are going to be heading towards megacities, over 8 million people. The decisions that we're making about how we plan and grow our cities are profoundly affecting ecosystem health, human health, and planetary health. Now, in our own case, in 2022, we published a Lancet series, a global health series on urban design, transport and health. I led a paper about what's next to provide some direction for the field. We came up with the idea, a much more complex model, that we needed to be thinking about 11 integrated planning policies or city planning policies that create 11 interventions, transport and urban design interventions that are regional planning and urban design planning. We call them the 11 Ds, they all start with D. And these are important because they affect not only our transportation mode choices, but all of our daily living opportunities that affect locational disadvantage, whether or not people have access to employment and education, whether they have access to social recreational opportunities, affordable housing, urban greening, how much time we spend commuting and how much energy we use are all to do with these 11 interventions. And these are important because they affect risk exposures for disease. They affect our individual risk exposures, our social risk exposures, but also our environmental risk exposures, which in turn affect our long-term intermediary and long-term health impacts, and ultimately the sustainability of the cities that we're building. Now, in this, we emphasise, in terms of our 11 integrated interventions, that we needed to have the interventions distributed because this affects locational disadvantage. Now, in my own case, I've been thinking about locational disadvantage from two perspectives. First of all, from SES, socioeconomic status. And this is really beautifully outlined in this study by David Crawford at Deakin University. In this study, we were looking at children's access to public open space and recreational opportunities for children. And we found that overall, no statistical difference between access to a park or the playgrounds that were present. But what did differ, highly significant, is all of the amenities were in those parks. We found, for example, that just in terms of walking paths, only 52% of people had walking paths in low socioeconomic, 70% in high socioeconomic. We found that in terms of trees providing shade, only 35% in disadvantaged areas and 77% in advantaged areas. And when we looked at the photographs, it became really self-evident about the differences. Yes, people had access in poor areas to parks, but look at the quality. It was so clear that the locational disadvantage associated with access to poorly maintained parks and few resources could not have been more stark. And children are playing in these parks. I started to think more about locational disadvantage associated with the spatial distribution of amenities. And this is shown in these maps of Sydney, of walkability on the left and access to public transport with a service every 20 minutes. So we're not talking a really frequent service, but that's pretty good, a service every 20 minutes and living within 500 metres. So anything that's pink is good. So you can see in terms of the walkability here of Sydney, not too bad in the inner city. Once you start to get out to the outer suburban areas, of course, everyone has to drive. And that means putting pressure on the family budget in terms of the cost of transport. It's not so bad in terms of, of course, in the inner city, you see lots of pink, good access to public transport. You also see lots of blue. Actually, it's about 57% of people have access to a service in Sydney with a service every 20 minutes and live within 500 metres of public transport, but over 40% of people do not. So we started to get interested in this whole idea of locational disadvantage. I wondered actually from your perspective, in terms of primary health care, whether this could partly explain SES and poorly designed neighbourhoods, partly explains lack of compliance. This is my little mum actually, taken a number of years ago. She had diabetes and she was told by her doctor she needed to walk around the block. Just go for a walk, he said. But when she started walking around her block, she had pretty good mobility, but nevertheless, there were lots of hazards for her, and there was a car park that she had to walk through. Not so easy. So he said, why don't you walk across to the shop? She lived across the road from the shop and she had to get over all these roads. This may explain why people don't comply with our messages when we tell them to go for a walk. Now, in my own case, why started locational disadvantage? This really was prompted by a public health policymaker with expertise in built environment and health. His name is Ian Butterworth, who was in Melbourne. He was a major driver of my team's research when I relocated to Melbourne in 2011. Ian was working in the northwest region of Melbourne, a region that was home to 4 of the 6 growth areas, growing very rapidly at about 2% a year. It doesn't sound like a lot, but it's a lot. A regional management forum chaired by the then Secretary of the Department of Transport, Jim Betts, now in the federal government of the Department of Infrastructure, had been established to manage that region's growth. And it was substantial. Actually, at the time, it was the fastest growing region in Australia. Jim used to remind us that in the next 10 years after I first went to Melbourne in 2011, the region was going to need infrastructure that was required for a city the size of Ballarat, whole of Ballarat, in 10 years. And in 20 years, it was going to need infrastructure for a city the size of Canberra. This is a lot of infrastructure that had to be delivered. Residents in the area were struggling to get the infrastructure they needed to meet their daily needs. Before my feet even touched the ground when I arrived in Melbourne, Ian asked me to conduct a series of interviews with all the CEOs of all the local government authorities, as well as all the government department heads involved in planning and delivering services in the region. He employed a local planner, Steph David, to accompany me to explain the planning system in Melbourne. I didn't realise at the time it was something I really didn't want to do. I was just go over there to start a new research centre or to work on a research centre, so I had a big team that I had to work with, but it was really such an opportunity. It was a gift. As a newcomer to Melbourne, I immediately established an influential network of policymakers and practitioners across government, and also gained insights into issues that they were confronting that might have taken me years, if ever, to fully appreciate. We started to map out what they were telling me in our interviews, and they were saying that there was low density housing on the fringe. It meant that the housing was affordable, but they had lack of employment opportunities. And the reason why the low density housing was a problem is because that meant that there was lack of amenity. So they didn't have access to services, public transport, and that was actually making it not so affordable to live on the fringe because people were spending a lot of money just to live. It was increasing the vehicle miles they were travelling, and there was high unemployment. And whilst they could see that for chronic disease, that some of the risk factors for chronic disease were evident in the way the place was being planned, what really was concerning them, particularly because alcohol and gambling facilities were going in first before people had access to anything else, there was a whole lot of social problems, significant drug and alcohol dependence, domestic and youth violence, high levels of unemployment. They were big problems that they were dealing with. Now, throughout the interviews, it became pretty clear to me that the underlying drivers in the area were these, what I would call social determinants of health. And the interviews highlighted to me that it wasn't the social determinants of health per se that were keeping up these policymakers at night. They were concerned about the impact of those factors on their own agency's agenda. traffic congestion, lack of facilities, crime, safety, alcohol and drug problems, domestic and other violence. If I wanted to gain their attention in terms of addressing this, if I talked to them about the locational disadvantage, their eyes would glaze over. I wouldn't capture them for a minute. We had to come up with something that was going to capture their attention. I asked Ian actually what sort of evidence he felt he needed to create environments that would actually address these issues. And he said to me, I need conclusive evidence, not just any evidence, conclusive evidence about the relationship between urban planning and health and the benefits of access to good places, healthy food, good public transport and local parks. And this evidence doesn't need just to be taken up by health people, it needs to be taken up by all the people who manage these urban planning portfolios. Because we don't want to just talk about this, we want to influence the policy and legislative environment. Now, for someone just moving to a city with a new team, it's a pretty big agenda, but it was quite an exciting agenda. So we started to talk about, could we reframe the social determinants of health in a concept such as livability? And the reason we chose livability is because at that time, Melbourne had been 7 times in a row given the Economist Intelligence Unit said it was the most livable city in the world. And despite the fact that this measure is really used just by international companies to decide what the hardship allowances that should be paid to executives, that's really what it's for. So it's really quite a useless, no one in Australia, by the way, gets paid a hardship allowance. All the Australian cities are very livable. But Melbourne policymakers, the government and the community had swallowed the Kool-Aid on Melbourne's livability, and it was highly valued. Hence, we decided that we would define livability through a health lens, and after a literature review by my then PhD student, Melanie Lowe, we defined a livable neighbourhood as one that was safe and socially cohesive and inclusive. It was environmentally sustainable, fundamental, had to be. And yes, we had to have affordable, but we needed also diverse housing to provide for different sorts of price points. But there's no point in having affordable housing if it wasn't linked by public transport, walking and cycling infrastructure to everything that people need for daily living, access to employment, education, public open space, shops and services. This was critical. And so then because Ian wanted conclusive evidence, and it wasn't truly conclusive, they weren't longitudinal studies, we used the cross-sectional data that was available to us, we needed to ask the question, are these underlying domains of livability associated with health and wellbeing? Hannah Badland in my team led the research program. We used geographic information systems to create built environment measures so we could objectively measure the environment. And then we looked at whether it was associated with a range of outcomes. We looked at walkability, access to public transport, green space, whether people had shops and services, social infrastructure. And the answer was yes. No surprises there. There was a strong association between all these underlying determinants and health and wellbeing outcomes. So we went a step further. One of my PhD, it wasn't a PhD at that stage, one of my team members was an urban analytics expert. We developed a livability index. We put down here, all the sort of domains of livability. We used all policy relevant measures of these concepts, and we put it into an index. And Carl then found that for every unit increase in livability, the likelihood of walking, cycling, using public transport increased by 10 to 15%, every unit increase. And more importantly, the likelihood of driving went down 12%. So we're talking about livability being really important for the way we move around our cities. We then looked at health department data and looked at cardiometabolic risk factors and found that again, of course, it was associated with walking for transport and achieving recommended levels of walking. But also living in a livable community was associated with lower BMI, and when they had certain attributes that make a place livable, diabetes too was lower, as was hypertension. But we also found that whilst livable neighbourhoods appear to be healthier and more sustainable, they were inequitably distributed. And so you can see here around the green is good, The livable areas were in the inner city, but when you start to get out into the middle level suburbs and out to the outer suburban areas, of course, it's not very livable in terms of all these attributes. They're really poorly served in terms of access. Now, this data could have just sat on our computers, as we'd always done in the past, actually. We'd never really put it out there. But I've been influenced by this report by the World Health Organization around hidden cities. And what this report said is that every city, no city is immune from this problem. All cities have inequities, and our job should be is to unmask these inequities in our cities so that people can actually see them. So first of all, we started mapping walkability. Anything green is good, anything yellow to red, you can expect everyone is driving. And then with funding that we got from the National Centre for Research, so the Australian Prevention Partnership Centre and the Clean Air and Urban Landscape, we upscaled this nationally. First of all, we did a policy analysis in 4 cities, Perth, Melbourne, Brisbane and Sydney. And then we took analyses to examine whether or not these policies were being implemented and to what extent. Who are the winners and the losers in the cities? Later, with prevention-centred funding, we upscaled this work even further, and we actually undertook more analysis in 21 cities, so that the federal government has 21 cities in its national performance framework. They're capital cities and regional cities, and so we upscaled this nationally and created all these livability indicators for the 21 cities in the Australian prevention and in the performance framework. And this was used to create the Australian Urban Observatory. Now, the whole idea of the observatory was to be able to visualise and to actually give this back to the community, to give the research back to decision makers as well as the community and to advocates. We had maps at suburb level, at LGA level, and for those who joined as a partner, because we wanted to have a funding mechanism that would ensure the longevity of the AUO into the future, we were able to give people at the sub-LGA level, so very small area level data. In addition, we created reports, citywide reports, that provided an overview of the results and also recommendations for improvement. Our aim was to enable decision makers to identify where the locational disadvantage was in their communities at the small area level to inform interventions. And we hope that this would be used by advocates and who could lobby for reform. The federal government did pick up some of our indicators and put them into the National Cities Performance Framework, but the government changed. And with that, the National Performance Framework was abandoned to better meet the needs of stakeholders. And then, although it doesn't seem to have been replaced, so no longer do we have these indicators at the federal government level. So I think this is a good reason why we really need to have surveillance systems outside of government. We need to have organisations like the Australian Urban Observatory. It's a way of holding governments to account and about reducing locational disadvantage. We upscaled this work even further when we established the Global Healthy and Sustainable City Indicators Collaboration. It involved over 80 collaborators, 25 cities, 19 countries and 6 continents. And our goal here was to facilitate the development of a global system of city planning and policy indicators. And that way we would be able to hold governments to account across the world with our collaborators. These results are important because they were able to unmask locational disadvantage through maps. We made these available through our global observatory for healthy and sustainable cities, and we're able to put on there all the information that locals could use to advocate for change. The evidence is quite clear. There are inequities within and between cities that are determined by inadequate and unambitious urban policies. And where there are good policies, there's often lack of implementation. And this is why I think the natural experiment studies, policy implementation, are so important. They're not the RCT providing the gold standard of evidence that is available for medical interventions, but well-designed natural experiment studies of policy interventions are the only choice available for studies about city planning and health. It's not possible to randomly allocate homeowners to go and live in different neighbourhoods. So well-designed natural experiment studies can provide a really important source of information. For example, in Western Australia in 2003, we commenced a longitudinal study evaluating the impacts of the West Australian livable neighbourhood guidelines on increasing walking, cycling, public transport use and sense of community. These were all objectives of the policy. They wanted to achieve this, and it had 4 elements to do that: community design, the movement network, the lot layout, and public parkland. When we did our evaluation, a 10-year study, we found that actually the policy wasn't working. People living in livable neighbourhoods were no more likely than those living in the conventional neighbourhoods to be physically active or to have better outcomes. Despite the hype, there appeared to be very little difference between livable neighbourhoods and other neighbourhoods in terms of the features on the ground that would make them more livable. So I asked one of our planning colleagues, Marion Thompson, she was a partner, how she felt the study could be strengthened. She told me very candidly that the flaw that they had with the study was we weren't measuring the success of implementation, and that one way to strengthen the research would be to benchmark and monitor how closely the policy was being delivered and where it was going off course. Fortunately, I had a brilliant PhD student working with me, Paula Hooper, and she took this on and started to dig deeper. She asked 2 main questions. Was the livable neighbourhood policy an example of policy failure, or was it implementation failure? To do this, she did a policy analysis. She found there were 43 policy standards that they wanted to achieve in this policy. And she used a geographic information system to develop spatial measures that could be used to objectively measure whether or not people had access, as it was said, 400 metres from a public transport stop, 500 metres from a park. Did people actually have access to this? Did they have a Main Street shopping centre? And she found that indeed the policy levers were actually highly effective. For every 10% increase in policy implementation, residents were 53% more likely to walk, 22% more likely to have a sense of community, 40% less likely to be a victim of crime, and 11% more likely to have better mental health. Rather than policy failure, this was an example of failure to implement, implementation failure. The policy was only 46% implemented, and the various levels of implementation across the different elements of the policy, the one that was needed most to encourage walking, for example, the community design element, was only 27% implemented. And so it was quite clear to see that what the problem was here, that we had a problem of implementation. Now, part of the problem, of course, could be that to build a neighbourhood takes a long time, and our 10-year horizon may not have been long enough. But actually, there's also what we came up with, the leaky pipe element, the leaky pipe problem. That we have a policy where we turn the policy on at the tap, and then along the way there is leakage. It goes to local government, it goes to the developers, and then on the way we get compliance on the ground. And what comes out on the tap at the ground is only a trickle compared to what the ambition of the policy was. So to overcome locational disadvantage, we need to understand where these leakages are occurring. Even if we had good policy, we don't get it on the ground. Why is that occurring? It's ripe for exploration and needs more research in this area is needed. Now, along the way, I think it's been important to hold governments to account. Hence, working with advocates has become critical in my team's research translation strategy. In my own case, I've had a long-term career working with the Heart Foundation. I've served on their research and practice committees. I've contributed to their evidence-based publications. I've helped prepare discussion papers that would assist them with their policy work, and my team has written briefs, policy briefs for their Active by Design website. In addition, we've worked with the Planning Institute of Australia. They've contributed to all of my policy advisory groups to shape and provide feedback on the research, disseminate research findings, and to influence practice. And this has allowed us not only to understand the types of research that might better help them make a difference, but also to amplify and disseminate research findings. Now, working with policymakers, practitioners and advocates has helped us understand what they need to change policy. This has led us to many of us asking questions about the dose of interventions that's required to inform all the standards that create new neighbourhoods. And to do that, for example, our team created a checklist of metrics for healthy, livable communities based on our CRE work. We had a Centre for Research Excellence, and we created this urban livability checklist. But other researchers are doing similar sorts of work. Xiaoqi Feng here at USW, Thomas Astle-Burt, they've been publishing highly influential research, for example, on the percentage of tree canopy using the 45 Up study associated with cardiometabolic risk and dementia. Now, this is really important research. It really does make a difference. It can go directly into policy, as it has done. Many of our metrics are being incorporated into the Victorian government's 20-minute neighbourhood policy, while Thomas and Xiaoqi's research has influenced the tree canopy requirement in the Victorian Planning Authority's precinct structure plan guidelines. This will determine what is built in Victoria or in Melbourne for the next 20 or 30 years. So you can see that this does have an impact when it's incorporated into studies. But there's so much more of that type of research that's needed, and particularly as we're trying to transform our cities to become 20-minute neighbourhoods, or in Sydney it's a 15-minute neighbourhood. How are we actually going to do that to achieve a good outcome? It's a huge challenge. So is this research making a difference? Well, I think it is. I think it's shifted policy in tangible ways in Western Australia, Victoria, nationally and internationally. However, given the topic of my talk was about if it's tackling locational disadvantage, I can be less confident about that. My team's research is designed, as Kingdon says, is to be prepared when the policy windows open up to assist the community, practitioners and decision makers to propose evidence-informed interventions that will promote health and wellbeing and that will overcome locational disadvantage. Now, I've showed you examples of where the research is already being used, and there's many more examples like that. But as we know, change in cities is a long-term process, and the proof of these impacts won't be evident for years. Moreover, as I've also shown you, even if we've had good policy, it has to be fully implemented. And as our research has shown, there is a gap between good policy and what's being implemented on the ground. Now, our policy indicators that we're distributing through the Australian Urban Observatory and our Global Observatory for Healthy and Sustainable Cities are designed as early warning systems so that we can benchmark and monitor changes in policy and policy implementation over time. And as Marion Thompson, my colleague, said, it will help us see whether the policies are going off course. Surveillance systems are an essential public health function. But if we're going to identify locational disadvantage, we need to be guiding evidence-informed goal-making. We need to be having action and advocacy. We need to be promoting and monitoring progress, and we need to ensure accountability. And we need to have someone then paying attention and using these surveillance systems. They're only as good as their use. Someone needs to be alert, and someone needs to be advocating for their use. Someone needs to be monitoring implementation and proposing changes as a result. So I'm reminded of this letter that Patrick Harris and his collaborators wrote in our Lancet Global Health letter to the editor, what gets done measured does not necessarily get done. We live in a political economy where there's different actors with different agendas, and some of these are not consistent with creating healthy and sustainable cities. Research about the politics of change and all the competing agendas is therefore vital to unmask the forces which are stopping evidence from being translated into policy and practice, to stop evidence policies being implemented, and to in turn create healthy and livable cities. These are usually the commercial determinants of health and need to be fully explored. So what can I reflect on what I've learned from this experience of doing this type of research with the benefit of hindsight? If we're going to tackle disadvantage, what I've found that in the research that I've done, and I'm sure it's relevant to yours, it's really important that we understand the policy world in which we're trying to influence. This is a really key thing in terms of talking to policymakers, particularly those outside of the health sector. If we want, and as Larry Green, the father of health promotion, once said, if we want evidence-informed policy, we need to have policy-informed research. So understanding the policy world allows you to do that. In my own team, we've got better of that over time. It's become sort of standard practice. We've gone from undertaking policy analysis in one city to going national to going international by working with collaborators. And a great example of this is the work that was done by of legal frameworks across all the Australian cities, which was done by Tracy Now and her team at Sydney University. In these studies, we asked the question, and I think it's a really important one, do we have the policies in place to deliver healthy, sustainable cities in Australia and elsewhere? We often don't, and this provides clues about what research is needed, but also what advocacy is needed to get us to the point where we do. On that note, it's really important, I think, to form really strong partnerships with policymakers and practitioners. Long-term, genuine partnerships, not just to get a grant, but genuine partnerships with them. Their jobs are really difficult. I think understanding the challenges that they confront in implementing or changing policy can provide really important insights into research that might make a difference. It's easy to criticise, but it's really hard to come up with the solutions and tell them what they've got wrong. But if we're going to have research that can really inform them to help them overcome those constraints, we need to work out how to do that. And that only comes from those close relationships. It's hard work, and but it's worth doing. It's important, it's rewarding, and can provide opportunities to learn an enormous amount. I think, importantly, it's critically important that we design research that speaks to policymakers. This paper by Steve Allender really influenced me, published in 2009. I never really forgot it. Tell us something that we don't already know or do. And I think it's really important not to tell people how to suck eggs, but to provide additional insights into what can change. Studies like natural experiment studies, economic analyses, community insights, insights of why a policy is going off course and how it can be corrected are all examples of something that will speak to policymakers, and generally they tend to like receiving it. Now, I think it's critical that we collaborate and work in multidisciplinary teams. I can't emphasize how important this is. It's difficult to do this type of research, but a good group of collaborators can help you celebrate the good times, commiserate when the times are not so good, and amplify your collective knowledge. This research is so much better when it's done together. Moreover, if we work in multidisciplinary teams, it can help us to have great leap forward in terms of applying well-established methods from one discipline and using them in another, in our own areas in health, and collectively we know so much more when we work together. I mentioned before that I think it's really important that we work with advocates because we need others to disseminate and amplify our findings. But I also think it's important, as a researcher working in this area, to be an evidence-based advocate yourself. There's varying opinions in the academy about whether we should do this. I think to overcome locational disadvantage, it's vital that researchers advocate in areas where they've got expertise and where they've got evidence. For example, speaking in the media, posts in professional social media outlets such as LinkedIn, responding to calls for submissions. We've done countless numbers of submissions where we put the evidence that we've collected into submissions. And I think when we're doing this sort of research, it's really important that we make sense of the evidence. It's not enough to say that a policy is not working. Digging down and finding out why the policy is not working and what can be done to improve a policy is really important and takes time, but it's critical. So trying to make sense of the evidence and make feasible policy and practice relevant suggestions about what's required is really important so that your research findings can be used and applied. Finally, I think what's really critical in this area is to be generous and to reciprocate. Research, as we all know, is a tough business. It's competitive and it's demanding. Resources are often constrained. So be generous with your students and your supervisors and your colleagues. Be a good collaborator by reciprocating when someone is generous to you. Now, as I've tried to reflect in this oration, if we want to achieve research that achieves health for all and to overcome locational disadvantage, we must understand the policy world that we're trying to influence. Our research must speak to policymakers and practitioners by being policy relevant, and it needs to be disseminated not just by researchers to themselves, but by internal and external advocates who can lobby and amplify the findings. Now, there are many more research questions on overcoming locational disadvantage that need to be explored, and I'm looking forward to hearing the talks this afternoon, which focus very much on what the community perspective is. For those starting out on your career, my reflection to you is to do what I did do in the first start of my career, to choose research questions that are both interesting to you and important to others. Don't be afraid, break the rules, and try and make a difference. For in the words of Ian Webster in his article in 2014, as he reflected on his own distinguished career, and it could be a mantra to all of us, if not you, who? If not now, when? And if not here, where? I wish you well in all your research endeavours, and I'm going to be looking forward to hearing your questions. Thank you.
Thank you so much, Billy. That's great. Now I'm going to invite Ian Webster up to just give us a few reflections on what you've heard so far today.
Well, I might call you guilty. You had a wonderful career. As you started, you described how reconnecting way back in the 1980s.
Yes.
And it's great to see how it's evolved. Great idea. I love the idea. Livability and the idea of having an observatory. But one of the questions I would like to sort of address to you, first of all, I notice a lot of your work is around Victoria, and of course it's extended beyond that globally, and I keep thinking about Sydney, although you did show some slides of Sydney. But one of the things that cities are having to cope with these days is the pressure to increase housing. I live in a part of Sydney which is well endowed, got plenty of tree canopy and green space, and you produced some reports there about the relationship between green space and tree canopy and issues related to dementia. And of course it would relate to other health problems too. But there seems to be quite a conflict, certainly in the government level in New South Wales, with the idea of planning, increasing the density of housing, and the idea of livability, which I understand, well, which I appreciate you're talking to us about. And in the area that I live, one of the things I'm concerned about is the loss of tree canopy and green space. So you've got these sort of conflicting national agendas in a way, housing, people, and then concentrations of housing and the livability of environments and the urban space where people can go out and play games, children can roam, there's safety. We don't have we've got areas in Sydney where there are huge pockets of heat stress because there's virtually no
Trees.
Vegetation to protect people, and we've got... So that's a bit of a rambling comment, but congratulations on your career and what you've achieved from those early days in the early 80s. And I love the ideas of livability and the observatory that you're speaking about. And I wonder if you might comment on these conflicting agendas of governments, housing people, density of housing, and livability.
Thank you so much, Ian, and I appreciate your comments. And it's really a topic that's close to my heart, and it would be one that I would be pursuing if I was not retiring. But what's happening is that cities around the world are recognising that we need to come up with 20-minute neighbourhoods or 15-minute cities, or I think it's 15-minute neighbourhoods in Sydney, as a way of ensuring that people have access to all the things they need for daily living. Now, density has got to be a part of that. If you look at the density of, say, Petersham, which I know I used to live there in the 70s, so, you know, it's around, I don't know, 35 dwellings per hectare, little terrace houses. So it's not a bad way of living. That's the sort of levels of density that you sort of need to be able to ensure that everyone has access to everything. We've been trying to estimate the levels of density that's needed, and we've come up with 30 to 35 dwellings per hectare. It happens actually to achieve the World Health Organisation's goal of 150 minutes. 25 dwellings per hectare is around it as well. So there's real benefits, because what it means is if you've got density, you have shops and services nearby. So we've really made some big errors on that. Sydney actually, and we do have all the Sydney results. We have some of the Newcastle's also got data in there as well. So all the major regional cities and Sydney are also in the Australian Urban Observatory. And Sydney has some of the highest densities in Australia, which is good in terms of the levels of density overall. The average is we're building around 14 dwellings per hectare. At 14 dwellings per hectare, you cannot have the butcher, the maker, the candlestick maker within a walkable distance. It means that we just get urban sprawl. My biggest fear now, because I have been a proponent of density, is that the way we're delivering the density is going to produce harm. And we did a report for the Heart Foundation on this in 2012, and it was about increasing density in Australia, how to maximise the health benefit and minimise the harm. Because I could see down the track that we're going to have a problem. And what I see is actually what's happening. We're building density in places where there are no shops and services, and so that's a big problem. And so that means that's just high density sprawl, in my opinion. So that's a problem. It's good around transit-oriented development, that's good. But the other point, as you raised, in already existing leafy suburbs where there's lots of tree canopy, we're losing that. And there's been some work done in Adelaide, where what they've found is that the heat island effects are massive. You suddenly get like a 4-degree difference between summer and winter. Summer and one suburb that's been gentrified or increased the density, and the others because they've knocked down the tree canopy. So there's all these, that's why I think it's such an area that needs so much more research. It's just, we're at the beginning of it, and it needs to be done sort of fairly quickly, because, and I think that's why the observatory is quite good, because we can track that over time. But we need to be alert and using the indicators in Sydney and other regional New South Wales cities to be able to track that. So I know that I'm probably getting wrapped up. You want to finish?
No, we can keep talking throughout the day. We've got breaks, we've got a panel where Billy's going to be staying on as well, and you're just getting into some interesting areas there that are around accountability potentially. But first of all, we're going to have a break. So time, cup of tea, cup of coffee, a few snacks.